So my name's Angie Wowczuk, and I'm Director of Rational Drug Therapy Program, and I'm also a Service Assistant Professor with WVU School of Pharmacy. And today I'm going to talk about psychiatric medications and their interactions with drugs of abuse. So before we start, I'll touch briefly on different types of interactions, and I'm not going to get too in the weeds with this because really the purpose for this talk and for your all's practice is just when there is an interaction, not necessarily the nuts and bolts of why things are interacting. So pharmacodynamic drug interactions are where one drug works at the same receptor site as another drug and causes either a competitive or an additive effect. Pharmacokinetics drug interactions are when one drug changes the level of metabolism, absorption, or excretion of another drug. So we know of cytochrome P450, which is an enzyme that helps the body metabolize medications, and it's actually responsible for metabolizing about 50% of medications that we take. So it's pretty important for drug interactions. It's the bane of every pharmacy student's existence because we have to memorize all of these individual enzymes and what they metabolize, but I'm not going to get into that with you all today because you guys don't want to know about that. There are a couple other mechanisms of drug interaction. So there's like phase 2 conjugation pathways, protein binding, et cetera. But again, we're not going to get into each of those. If anybody does want more in-depth information, though, please do reach out to me after the presentation. All right. So mental health and illicit drug use. So these go hand in hand a lot of the time. So very commonly they have substance use disorder, or they just recreationally take drugs and they have a concurrent mental health diagnosis. So this does come up and is a pertinent part of practice. And it's important to be mindful of potential drug-drug interactions, even with drugs that we're not seeing on a medication profile. So it's important to ask a lot of questions. And also important to ask a lot of open-ended questions. And I'm going to ask for a little bit of participation from the crowd, and you can either unmute or you can use your hand raise button, or you can just raise your hand if I can see you on the video. But how many prescribers or even pharmacists have a conversation about illicit drug use with their patients? If this is something that you typically do, go ahead and raise your hand or say yes. Some hand raises. That's good. It's really important to do that because, like I said, I think it happens a lot. And unless you're asking these questions, most patients aren't just really going to volunteer that information. And we want to keep it on our radar. So we want to make sure we're not existing in our treatment silo and that we're treating the patient as a whole for everything that they're doing inside and outside of the provider's offices. So much of our knowledge in this space actually comes from some case reports and different things. There are some trials for some of the things that we're going to talk about today, some of the very common things, but as you can probably guess, it's not very ethical to hold really great widespread clinical trials on. So much of the knowledge that I'm going to talk about comes from case studies. And often patients do underreport use of illicit substances. So education, even if we're not seeing that or if they're not volunteering that information, is important as well, especially if the interaction is something that's a severe contraindication. Okay, so our key concerns are obviously the effectiveness of the mental health medication. So we want to make sure that their mental health is being adequately treated and that anything that they're doing either recreationally or habitually is not going to interfere with the effectiveness of that medication. We want to make sure that there's no unintended side effects that are being caused by this example. So for example, stimulant drugs, there are also illicit stimulant drugs or cocaine. They can heighten the side effects of some antidepressants or some stimulants. And sedative drugs like alcohol and opioids, they can increase drowsiness or dizziness that can be side effects also from other actual medications they're taking, like antipsychotics or other medications. And then, of course, toxicity is always on our radar. In some cases, combination of illicit drugs and mental health drugs can lead to toxicity, and this can be particularly dangerous as it may result in severe health problems. It can cause seizures, heart issues, and some illicit substances might either increase the potency of a medication or of a toxic buildup in the system when combined. So we want to make sure on those things. So I made some nice slides with some charts here, and I gave my presentation to everyone so it can be dispersed if you all just want this as like a quick reference. I tried my best to color coordinate. So of course the green is going to be okay and commonly used. Yellow is going to be you would use with caution, weigh the risks and benefits. And red would be something that you should avoid, and it would be contraindicated in a patient with either current use or history of use with those products. And again, this was a little tough to do because with a lot of the things I'm going to talk about, frequency of use can make a for example, when I talk about alcohol, somebody who has a drink once a month, it's going to be a very different risk versus benefit ratio versus somebody who has severe alcoholism who's also taking a certain mental health drug. So keep those things in mind as we talk through these slides. So first one we'll talk about is cannabis, and it can be used medically or recreationally. So we might be seeing that disclosed by the patient easily, but other patients, especially those using it recreationally, might not disclose that unless you bring up that conversation with them. So cannabinoids are metabolized by the CYP complex. So drug-drug interactions can occur, and interestingly, form of smoking can induce certain CYP enzymes and cause an effect that can be enhanced when something is smoked with cannabis. And so when tobacco and cannabis are smoked together. So that's something to keep in mind too, because a lot of times that frequently overlaps as well. For cannabis, it can interact with benzodiazepine. This is a cautionary. It can have additive sedative effects when combined. So we know benzos are sedating. Cannabis can also be sedating. So that can be problematic for patients if they're driving or operating heavy machinery as a part of their job, or if they're a truck driver. So we want to make sure that we counsel patients, particularly if they're using both products, because you can use benzodiazepines not on a scheduled use. You can use it as needed if you just have some anxiety or need it for sleep that night. But if you counsel the patient on it, they can have a heads up on maybe I just don't do both within the same time period, and that can be a helpful thing to diagnose or to counsel on. So cannabis use with tricyclic antidepressants, TCAs, this can cause significant tachycardia and it can cause some delirium as well. For cannabis with naltrexone, I point this out because for naltrexone, we have started kind of tracking the data with that with rational drug, and we found that it's used for quite a bit of different mental health diagnoses. So it's used more often than I think I thought before I was compiling that data. So I do point it out. This is an interaction at the CYP pathway. It slows the metabolism of the cannabis. So it can cause the cannabis to stay in the system longer, potentiate its effects, and one of its effects can be tachycardia. So you can see some of that. If you have some other patient or some other treatment options for a particular patient, then it might be best to try that. But if not an absolute contraindication, if you've had a patient on a TCA, they're doing very well, and then you find out, oh, we have some cannabis use, it just might be something to caution them on. And chlorpromazine can cause chlorpromazine clearance to be potentiated, and it can be even more so potentiated if the patient also is a tobacco smoker. So that's something to think about. And they did have a clinical trial on this, so it actually showed a 50% change in clearance in patients who are recreationally using cannabis. So the official recommendation or the guidance that you would give would be if you need to use them together, you can. You just might adjust dosages accordingly and monitor plasma levels if it's possible to do that. SSRIs, I put this in green. It's pretty commonly used, generally thought to be okay. It's used so frequently in practice, and there's been no mass case report of significant interactions. There was one single case report that described mania in a patient. They were using fluoxetine in cannabis, and really the case report was a little flimsy in identifying the causal relationship. So I wouldn't worry about that so much, and I would think that interaction would be fine. It would be probably kind of hard to say that you wouldn't give an SSRI to anybody who who smokes cannabis at any time. So I think that that interaction is probably okay. So I do list it in green, but for completeness sake, I put the report of the one case study on the slide. So alcohol, very common. And again, we have different degrees of alcohol use, so those can all play a factor in our risk versus benefits weighing with these combinations. So we know alcohol is sedating, and it can have a combining sedative effect if you combine it with something that causes sedation. So we'll keep that in mind. It can also be something to keep in mind for patients who are elderly, might be inclined to fall. So our patients above 65. And it can also be something to factor in if we're thinking of situations where impaired judgment can come into play, and then vehicle accidents. So something to think about. First, we'll summarize. So there has been a study done that shows a correlation between alcohol use and reduced efficacy in treatment with SSRIs. And this was a really interesting study. It was actually a decent patient population that they analyzed. And it was even done from the alcohol standpoint of patients who had one alcohol consumption per day. And so it wasn't, looking at people with severe alcoholism, and it did show some statistically significant differences in treatment efficacy. The study linked the findings to the depressive effects of alcohol, so maybe saying like it's adding to their underlying mental health diagnosis, and so that you need a higher SSRI dose to overcome that. But I thought that was a really interesting study worth pointing out. So you don't need to avoid that interaction, but it might be something to counsel patients on, that it's not good to routinely use alcohol while you're on an SSRI if you're trying to get a handle on treating their depression. Next, we'll talk about TCAs, or tricyclic antidepressants again. They are more sedating than SSRIs, so we want to keep that in mind. You've got a lot of increased sedation with this combination. And it also interferes with the first pass metabolism of amitriptyline particularly, and that's going to happen in the liver, and this results in increased amitriptyline levels in the blood. Keep that in mind. And alcohol-induced liver disease would further impair this, so that's, for those patients, you want to think about that as well. Atypical antipsychotics, they've been shown to be more problematic when combined with alcohol. In particular, we look at olanzapine and paliperidone and risperidone. For olanzapine, we see some increased sedation and orthostatic hypotension. So again, for our patients that are prone to that, particularly the elderly sometimes, that might be a combination to avoid. For paliperidone and risperidone, we see increased in CNS depression for that combination. Alcohol and our Z drugs. So the Z drugs are medications that are used for sleep. So zolpidem and Zalpilon, medications like that, we do obviously see an additive sedative effect. So alcohol does interrupt sleep. It gives us a worse sleep score when we've been drinking alcohol before we go to sleep. So it's generally good to avoid that combination. But in particular, there is some studies that show that with use of alcohol and zolpidem, you want to avoid that due to respiratory depression and problematic sleep behaviors. So problematic sleep behaviors can be things like sleepwalking, or if you get night terrors or whatever it might be, those can be exacerbated with that combination. Alcohol and benzos, again, we've got two sedating products here, so it can increase sedation and impair psychomotor skills. So now we'll look at cocaine with some drug interactions with mental health medications. So cocaine can be problematic when combined with SSRIs, and in particular I listed a few there: so citalopram, fluoxetine, sertraline, and escitalopram. The first effect that we'll talk about is the augmentation of the effects of the cocaine. So this is based on actually clinical trials, but on rodents, so not in people. But at this time, it's also expected to be an interaction in the CYP and cause a metabolism of cocaine to be inhibited by some SSRIs. So we point that out. And it causes cocaine to stay in the system longer at higher levels, which of course can increase the likelihood for toxicity and all of the negative things that can come from cocaine use. There are also some case reports of serotonin syndrome in patients who use cocaine with SSRIs. And this is because the cocaine does prevent serotonin uptake. So the incidence is pretty rare, but it could be something to take into consideration if you have a patient who is or experienced or expected to need really high SSRI levels. You would probably want to avoid that in a patient who recreationally uses cocaine. Methadone and buprenorphine interact with cocaine via the CYP pathway. So cocaine is an inducer for this enzyme. It causes more rapid metabolism, resulting in a reduced methadone and or buprenorphine combinations. Obviously, if we're using these two medications for opioid use disorder, we don't want to reduce the efficacy of our opioid use disorder medications, so that's important. For the tricyclic antidepressants, so nortriptyline, amitriptyline, desipramine, thorazine, imipramine, we have augmented cocaine toxicity and lethality, so we want to be mindful of that. Lofexidine was actually studied in a double-blind, very small clinical trial with cocaine, but it was studied. 11 participants actually completed the study, but the study did find that there was an increased incidence of hemodynamic side effects. And so patients had significantly increased heart rate and blood pressure, and their recommendation would be to only use it in appropriate patients. So if a patient has cardiovascular risk already, it would not be an ideal thing to use. Disulfiram, I put this on here for completeness sake. It's really more second line for alcohol abuse, not really first line anymore, but I'll put it on there just to include it. Disulfiram can increase plasma concentrations of cocaine, resulting in an increased heart rate and blood pressure, and this just inhibits the metabolism of the cocaine. So club drugs, MDMA, and also known as ecstasy or Molly. So this can interact with some psychiatric medications. We do have one contraindication that I'll note on this slide. MAOIs are not commonly used anymore, but again, for completeness sake, I'll list it on here. So deaths have been reported with moclobemide, as it is a really strong inhibitor of the MDMA metabolism. It can cause toxicity for this reason, and it also reduces the breakdown of serotonin. So they have had 4 deaths occurred related to serotonin syndrome in young adults and this combination. So that's something to keep in mind. Phenelzine also inhibits this pathway. It can cause hypertension, diaphoresis, altered mental status, and hypertonicity. For methylphenidate, patients who take this combination and then recreationally use MDMA were shown to have a hemodynamic adverse effect in a double-blind placebo-controlled trial. So they did have a trial for this combination as well.
Angie, did you see the comment in the chat?
No, I did not.
Okay. Lauren Swagger asked, are those cocaine-specific interactions or would they apply to all stimulants?
Get back to that slide. So do you mean like the ones listed in the second column, would they also interact with stimulants?
Well, I guess I was asking more how much it was cocaine specific, like to like SIP or the interaction specifically with cocaine, or if it was more mechanism of action, like stuff that applied to the whole class of stimulants was what I was trying to tease out in my brain.
Yeah, this is specific to cocaine for these interactions.
Thanks.
Yeah, of course. Sorry, yell at me if you all put something in the chat. I'll look at it from here on out. All right, some other notes. So methamphetamine use is popular in West Virginia, so wanted to note that. So methamphetamine use with Haldol or haloperidol can cause drug-induced Parkinsonism. So there has been some literature published that showed the co-administration can cause this effect. And I wanted to discuss this because we have a lot of this use in West Virginia. And also it seems like with the studies, so the symptoms resolve over days or weeks. So this can be kind of a significant interaction. And I think Haldol is used commonly in the inpatient setting for patients. And so because it's days or weeks, that it's infrequent to use haloperidol. In the elderly, or if patients are on long-acting injectable formulations, it can actually be weeks or months. So again, it's kind of a significant interaction. I didn't list it as the green, yellow, or red on here, but I would avoid that if possible. The mechanism of it is that the methamphetamines reduce dopamine and haloperidol blocks the D2 receptors. So this results in the decrease of dopamine and it leads to the drug-induced Parkinson's symptoms. Concurrent use with methamphetamines and some TCA can cause hypertension, and it can also cause CNS stimulation. So again, want to be mindful of our patients' comorbidities. Synthetic cationines are bath salts as we commonly know them. This is a little trickier because these aren't really a consistent product across the board. So there's usually different additive things in bath salts. It's not really just one product or compound that you can identify. But I'll talk a little bit about some of the case reports that have been out regarding this interaction. So there has been death associated with olanzapine and mirtazapine usage with bath salts. The mechanism is really unknown, again, because this is kind of hard to nail down just because of the variance of the bath salts. It can, like the death that was reported in this case study. So it's actually with one patient, and I'll mention this isn't a mental health drug, but diphenhydramine or Benadryl was linked with a death with bath salt usage as well. In the death with the diphenhydramine, the cause of death was actually noted as high levels of the bath salts, and that was found to be the toxicity. But it does interact on the CYP pathway, so that's why they linked the two together in the case report. And it can cause the bath salts to build up in the system and become even more toxic. Okay. Psilocybin, so this is a compound found in some mushrooms that can be used recreationally, and it acts as type of psychedelic, causing hallucinations, causes euphoria, so it's recreationally used by some patients. It's metabolized by the enzyme that is inhibited by haloperidol, so it causes it to build up in the system, and because of this, it can increase the psychomimetic effects. LSD I included in here. I don't know how popular LSD usage is anymore, and I've had a little trouble finding its incidence in West Virginia, but I'm going to mention it because it does have some interactions. So when taken with imipramine, disipramine, and clomipramine, it can cause physical hallucinations, psychological and increased psychological responses to LSD, which obviously LSD causes hallucinations anyway. It can up this and increase it and cause it to be much more pronounced. The mechanism isn't really well understood, but it is a CYP pathway. What they're inferring is the interaction. Not too well studied, but they do have some case reports that link this interaction together. Kratom I have on here, so this is another kind of random thing. I would have normally skipped this, but I live in Wellsburg, West Virginia, or I'm from Wellsburg, West Virginia. That's in Brooke County, Northern Panhandle. And every time I drive into town, there's a sign that advertises Kratom. And so maybe this is more popular than I'm aware of. And as I was preparing this presentation over the last month, I was taking my son to T-ball in Westover in Morgantown, and I saw a big sign for Kratom over there as well. So I'm going to mention it in case this is more popular than I'm aware of. And Kratom has opioid and stimulant-like effects. So this is taken for its feel-good effects, obviously, and help with symptoms of withdrawal from substance use disorder. So it's been linked to seizures when combined with modafinil. So I wanted to mention that because seizures and death can be something that happens secondary to. There was also one death reported in a patient who combined it with Seroquel. I didn't include that on the slide because it was just one death, and it was a very loose association between the cause of death. So I hope that's helpful. Again, with these slides, just Keep in mind that the red, green, and blues are just relative to frequency of use and dosages of the mental health medications too. That can definitely play into effect as we look at these drug interactions because a lot of them are related to metabolism and building up in the system. Do y'all have any questions? I'm gonna stop. All right. So yeah, Kelly has my slides. If anybody wants them or wants this as just a quick reference, she can disperse those.